Hello everyone, today's our topic is anti-diabetic drugs. In this video we are gonna cover classification, mechanism of drugs and structure of drugs. Where do we use or why do we use anti-diabetic drug? We use in treatment of the type 2 diabetes mellitus. In type 2 diabetes mellitus, our beta cell are get damaged or not able to produce enough insulin. Beta cells are present in pancreas, and if the insulin is not produced enough, so it will cause increase of glucose in blood, which will cause hyperglycemia. So we administer these drugs which will help or push the beta cell to produce more insulin to decrease the glucose level to some normal level. Now the classification of anti-diabetic drugs. Anti-diabetic drugs are also called as oral hypoglycemic drugs because first they are administered orally, and they are used in glycemia means glucose and hypo means decrease, to decrease the level of glucose in our body by orally administration. Now classification of drugs. First, bigonides, sulfonylurea, maglitidines, alpha glycosidase inhibitor, thiazolidinediones. In bigonides we have metformin. In sulfonylurea we have two, first generation and second generation. First generation, and under first generation there is a tolbutamide and chlorpromamide, and second generation we have a glipizide and glipyramide and other further drugs. In maglitidines we have a repaglidine and netaglidines. You can see the glitine part is suffix is same. In alpha glucosidase inhibitor they are acrabose and voglibose, both part is similar. And then we have a thiazolidinediones, pioglitazones and rosiglitazone. The glitazone part is same. Now we will talk about the structure of sulfonylurea. First, draw the general structure: benzene plus sulfone plus urea part. You can see the urea part here. This sulfonyl plus urea is called sulfonylurea, and at the para position we have R1, and at another N nitrogen we have R2 part. Now we will first talk about the first generation. In first generation we have a tolbutamide and chlorpromamide. But you can see that at R1 we have a CH3 group. Here we will add CH3 group, and at R2 we have C4H9. You can, by the name you can understand, like butane. In butane we have a 4 carbon C4 at R2 position. Then we have a chlorpromamide. In this, at R1 position you have chlorine. R1 position chlorine, and R2 position you have a propane short form, C4H, so C3H7, chlorine and propane. Then we have a second generation drug, glipizide and gliprimide. The structure is little bit hard. At R1 position this is added here, and R2 position you have a cyclohexane. Then in gliprimide you have this structure at R1 position here, and this cyclohexane plus methyl here at R2 position. Now the thing is, glipizide and gliprimide is 100 times more potent than tolbutamide. So that's a plus bonus point for these drugs. And why we have first generation and second generation drug? We develop new generation drugs or new drugs generally because the first generation or previous drugs have more side effects than its use. More side effects than its use, or not effective, or not giving bad side effects. Then you have a bigonides. You can understand this means bi means two, and guanides means two. Gunide means guanide structure, and this is the guanide structure, means two guanide in combination will form. Metformin this structure is one unit, and this is second unit, and then we have another extra group is methyl group, and that's how simple is. You can understand by its name. Common leaves, this drug is very common leaf. Then we have a maglitidines. In maglitidines we have nataclidines. You can remember this structure by, this is large structures, you can understand remember this by dividing into structures. You have first benzene, C2, H, like this. Then you have repaglitine, have a hard structure, so you don't need to remember. Now we will talk about the mechanism of action of drugs of sulfonylurea. What is do? Beta cell stimulating and increase the insulin production. Now we will talk about the mechanism. What is to reduce the outflux of potassium. Reduces outflux by binding to sulfonylurea receptors. These drugs will bind to the sulfonylurea receptor and prevents the outflow of the potassium present on ATP synthesis. Bind with the sulfonylurea receptor present on ATP sensitive potassium channels, which cause depolarization, and followed by the calcium entry and insulin secretion. The depolarization will cause the entry of calcium ions and insulin secretion. Influx of calcium causes insulin exocytosis. Only effective on patient, the sulfonylurea or antidiabetic drugs are used in which the beta cells are properly functioning. Like they should at least have working beta cells in less amount, it's fine. And the second action is suppress glucagon levels. Glucagon produces the glucose in body. The second generation have additional effect that it increases the sensitivity of peripheral tissue to insulin. If it increases the peripheral tissue in insulin, then it will promote breakdown of more glucose. Now we will talk about the structure activity relationship of this. First step that you have first draw the general structure, this sulfonylurea structure. Then we will talk about this SAR. R1 and R2 should be lipophilic in character of their action. When we have a lipophilic means that we need to transfer it into the cell membrane, and if it able to go into the cell, then it will bind to the receptors. Para position of R1 substitution should have halogen in like chlorpromide, or alkyl group in tolubutamide, or methionine to increase the hypoglycemic activity. R1 substitution para position with larger substitution are more potent. In case of like second generation drug glipizamide and glipizamide, large substituent group, we have large groups are more potent as compared to first generation, because R1 substituent distance to the sulfonide nitrogen helps in binding with receptors. If like in this we have a large group here, so it can bind good with receptor sulfonide. This nitrogen sulfonide amide nitrogen will good able to bind with receptor more effectively, as it not going to be hindered, which enhance. Glipizide is more effective than first generation group. Then R2, we will talk about R2 substitution with different N-alkyl group affect the potency of oral hypoglycemic. N-propyl to N-hexyl and N-phenyl aromatic heterotonic substitution are more active, like glipizamide. Like in this, you can see having this group. This is our general structure, and having the phenyl group or N-hexyl group, cyclohexyl group will increase or make the more active drug. Like that. And if we attach the R2 substitution of R2 with N-methyl, N-ethyl here less and low active respectively, and more than 10 to 9 and nitrogen alkyl containing substance, no potency. If we have smaller groups, it will decreases the activity. If we have like hexyl or phenyl group, it is the best. If we have like 10 to 12 carbon chain, then it will be no potency, bad, very bad, no potency. Now we will talk about pharmacokinetics. It is administered orally. Its protein binding is 90 to 98% metabolized in liver and excreted through urine. Duration of action of second generation has more like 24 hours, while the first generation group has like 12 to 16 hours of drug duration of action. Adverse effect of the second generation is less usually, that's why we have developed common sense. The adverse effects generally are coma, weight gain, fluid retention, oedema, skin rashes, cholestatic jaundice. Contraindication, like when should we not administer this drug, to whom? Pregnant women, we should not give pregnant women the drug. It will may cause the fetal hypoglycemia. Not used in gestational diabetes. This drug should not be gestational diabetes. Like gestational diabetes is happen for very small time of amount after the pregnancy, so it will eventually goes away. Now we will talk about the meglitidine mechanism of action. In this we have dapagliflozin and etaglidine. They are short acting drugs and have a rapid action, also known as a insulin secretogoginase, as they have enhances the insulin secretion, stimulate the beta cell secretion. It has the same mechanism of action like the sulfonylurea, similar to administered, but this you should know that these drugs are administered before meal to reduce ppg, postprandial glucose level in type 2 diabetes. They similarly blocks potassium channel outflux. In this we are giving before the meal so that there is less weight gain. Allergic reaction, no, as in sulfonylurea, sulfur cause allergy. Less risk of hypoglycemia. Now we'll talk about biguanide structure. We already talked about 2 guanides plus 2 methyl. First choice for treatment, not lower BGL blood glucose level, no stimulation of beta cell. metformin इंसुलिन सेंसिटाइजर है. It increases the uptake of glucose, decreases the formation of glucose, absorption, decrease of glucose from GIT, so the glucose will present in more in body for more time. Insulin binding increases. It plasma half-life is 2 to 3 hours and duration of action is 6 to 10 hours. It is not bound to plasma protein and not metabolized and excreted unchanged by kidney. Clinical use of metformin is used in type 2 diabetes. First choice of drug. It instead of stimulating appetite called anorexia, treatment of obese to type 2 diabetes, we can use to give in obese. It can give in combination with sulfonyl, meglitine and glitazone to treat insulin resistance syndrome. Now we have adverse effect of metformin is nausea, metallic taste, anorexia, flatulence, diarrhea. Long-term use decrease the absorption of vitamin B12. It may also cause rarely hepatic acidosis. Rarely it occurs. It primarily lowers the fast drug plasmic concentration, decreasing hepatic gluconeogenesis, increase insulin stimulation. Thank you guys for watching my video. and we will later talk about the two classification of alpha glycosides and thiazide in our part 2 video. Thank you.